Hello, and welcome to this Oncology Data Advisor interview. Today, we are joined by Dr. Jeffrey Velotta, a thoracic surgeon at Kaiser Permanente Northern California and expert contributor for the Mesothelioma Center at asbestos.com. Dr. Velotta is here with us today to discuss the overall methods and results of the recent MARS-2 study, as well as the current evolving treatment landscape of mesothelioma. Dr. Velotta, thank you so much for being here today. Would you like to begin with introducing yourself and a bit of what you do?
Yeah, hi, I'm Dr. Jeff Velotta. I'm a thoracic surgeon, and I run the mesothelioma program from the surgical director side for Kaiser Permanente Northern California. So have a strong interest in doing mesothelioma clinically, but also have a research interest in it as well. So happy to be on.
Terrific. Definitely excited to talk to you. So, to begin, could you tell us a bit about the MARS-2 trial and what it's set to accomplish?
Well, I think to start off about what the Mars 2, I think that obviously a lot of us feel that there's some issues with it and whatnot, but I applaud the investigators for essentially going through this rigorous randomized controlled trial. But essentially, what really was tried to be done, which I'm not sure is was completely accomplished, but was to determine whether or not there was any benefit of surgery when you add that to chemotherapy versus chemotherapy alone in patients with pleural mesothelioma. And their conclusion basically was with the MARS-2 trial, based on the way they did the trial, the way the patients they studied, and all of those limitations, bottom line is they came out and their conclusion was that surgery was not beneficial, and that patients with just chemo alone versus the chemotherapy plus surgery group, the chemotherapy alone group had a improved survival, and their recommendation was to that surgery does not have a benefit essentially in the treatment of mesothelioma.
With, a bit of the results that you just explained for us, could you go into what are the significance of these results? Like, what is the conversation that it's bringing up in clinic and treatment of mesothelioma?
So it's a problem. It's a problem for really the treatment of mesothelioma because people that don't know the data, don't know the field, or haven't treated these type of patients, or tend to not understand the nuances and misinterpret the study, which is the majority of the oncologists, right? The majority of the providers out there that don't know much about mesothelioma in the first place, because it's such a small subset field of us that it's leading them to essentially not even uh, give surgery as an option, which was not the case before. And so now, not only was mesothelioma prior to Mars 2 already like this kind of field that people didn't understand, and a lot of patients with even early stage mesothelioma were not getting adequate assessment by surgeons, medical oncologists, radiation oncologists, because they just thought it was a death sentence, or that there was no treatment to do, or that you couldn't do it, or all these misnomers. That was already happening before Mars 2. Now with Mars 2, that's even accelerated more, where there's even more patients that are potentially treatable with a multimodal approach, meaning surgery, systemic therapy, and or radiation, aren't even getting to see us. It's not even being referred anymore. And so what we're seeing around the country is a dramatic drop off of treatment of mesothelioma to just relying on old school, which was now we're just going to rely what they always have relied on, which has never worked well classically with mesothelioma, but is systemic treatment. So going to a medical oncologist or palliative care because there's just no more hope because now surgery is off the table, right? And that's not what the Mars 2 trial really showing, but that's what people are interpreting Mars 2 as, unfortunately. And so we're seeing a lot of referrals drop off. We're seeing a lot of patients not even get to see us. Whereas before, you'd easily have a multidisciplinary view of oncology, radiation oncology, and surgery, and all of us can combine along with radiology and pathology to determine what is the next step. And that should be the right way to do it, whether it's surgery or not, a multidisciplinary viewpoint. And we're not seeing that anymore. We're now just seeing either not presented to tumor board or not even referred to have a surgeon and a medical oncologist looking at, to now just maybe just a medical oncologist making their call on their own about what to do up front without weighing in a multidisciplinary fashion with other specialists not related to medical oncology. So I do think it's a problem, and that's what we are seeing right now.
I wanted to ask because you were mentioning the importance of multidisciplinary care. So, when clinicians are seeing the results of the Mars 2 trial, or just in general, why would you say and how would you advise clinicians to recognize and strive to implement these individualized and multidisciplinary approaches for surgical options and recommendations for patients with mesothelioma?
Yeah, I know. I get what you're saying. So I think what I would recommend is that for clinician providers, wherever they're practicing, whatever their specialty is, whether it's thoracic oncology or not, or general medical oncology, is to remember that, yes, while the Mars 2 trial is a randomized controlled trial and we applaud their effort and whatnot, there are a lot of flaws and limitations to it. And that even despite that, if you actually look at whether it's the NCCN guidelines, which a lot of medical oncologists should be going by, and or the newly published by Hetty Kindler and team, the ASCO guidelines for the treatment of mesothelioma, that they recommend a multidisciplinary fashion, and they do not say no surgery at all. They say surgery could be considered in this setting and after a multidisciplinary tumor board review and all that. So even in the guidelines right now, even despite Mars 2, the Mars 2 trials have made the guidelines kind of slightly change it where it's not as open-ended like surgery for any patient or whatnot. They're a little bit more trying to make it more, early stage and carefully selected and epithelioid, and that's fine. So that's made it more nuanced and more specific. But regardless, these patients should be getting evaluated still with a surgeon or by a surgeon, and then by a medical oncologist, by a radiation oncologist, by pulmonary, whatever, all that multidisciplinary review. So even in those guidelines, still, despite Mars 2, they still recommend surgery is still in that armamentarium. And so it's just because Mars 2 has potentially biased a lot of people's views already that already didn't really know much about mesothelioma or thought mesothelioma was a death sentence and that they don't know what the surgery even entails, or they're going off of old data. That's just like the nail in the coffin. Oh, Mars 2 randomized controlled trial, because that's how medical oncologists are trained. And it's not wrong of that per se. It's just there's not enough out there currently that's really not combating that, but coming out full force. Now, ASCO did come out full force after that and did say that surgery can still be an option for early stage epithelioid disease. But again, that's in a subset, people that follow ASCO or follow those guidelines. So what we've done to also help alleviate that, we actually formed our own Society of Thoracic Surgeons, which is the biggest kind of guidelines and national syndicates for overall cardiothoracic surgeons. And we have formed an expert consensus document consisting of a multidisciplinary panel, radiation oncology, pathology, medical oncology, and thoracic surgeons on our expert consensus statement on the role of surgery. And we are clearly going to say there is still a role for surgery in these certain settings, and that these patients should be still viewed and seen by surgeons. So we are going to now come out with ours. So hopefully the more societies that come out and the more that's known and publicized, whether it's social media or online or all the different ways that electronically that we can do this, providers and patients hopefully will know that no, I still have an option, right? So we don't need to just get it to the providers. We need to get to the patients. We need to get to the advocacy groups. We need to get to the mesothelioma support groups that knows the people that are in this field that know this field well are still absolutely doing surgery. It's just we're not getting as many patients anymore to even evaluate whether surgery is an option. And that's a problem when there's already a bias where the experts aren't seeing these patients anymore. So that was another thing that we did to combat that. Besides the other guidelines, we said that this is what we're going to do. And hopefully through this collaborative effort, we can, combat some of the maybe misinformation that may be going on.
Do you think there will be an expansion of the Mars study?
Yeah, this study, absolutely. This study was controversial and stuff. Remember, this study took several years, over 6, 7 years to develop, and that's what's great. But that's over a long period of time, and the field has changed so dramatically, even with mesothelioma and the way we kind of do the surgery and whatnot. So it's not that we don't think that that more prospective randomized controlled trials or even pragmatic clinical trials should be done for mesothelioma involving surgery. It's just that we think essentially, quote unquote, a Mars 3 should be done, where you specifically change things a little bit up, where you don't have so many of these limiting factors and confounding factors, which may have messed the surgery group up. And so essentially a Mars 3 trial where you would compare surgery, direct surgery, upfront surgery, followed by chemotherapy versus just the same type of patient that's randomized that could undergo surgery, that's early stage and has, appropriately staged with a mediastinoscopy and or EBUS and a PET scan and all that, and then just undergo chemotherapy. And then you compare that group. And then you make sure it's under high specialized volume centers where they perform lots and lots of surgery with the whole team, not just requirement of a few surgeries as a high volume and all that. And you standardize the surgery a little bit more where we kind of know, nuances with the surgery and whatnot. And then you go through that trial. And then you see the results. And then if we see that trial as like surgery has no benefit, which I don't think that would be the case because we have so many retrospective studies and so many real world studies showing that surgery is beneficial. Again, it's not randomized controlled because we're truing it real time and we haven't had time to wait for that long. But if we do want to wait that long and do another 6, 7 year trial, I think you would see, and if that truly did show that surgery wasn't beneficial, that would be different. I personally, if that showed that surgery wasn't beneficial in that certain population that I just kind of was speaking to, then yeah, I would stop doing surgery. I think that would say, okay, we finally know. But the likelihood of that happening now is so rare, based on all the issues that this trial had to do and everything. I don't know if we could get there. A lot of us want to do that, and a lot of us still are open to doing that. So I don't want to shut the door on that. But until that data comes out, about the real answer of what if surgery has a role for mesothelioma, I think a lot of us are going to continue to do surgery. We're a little more selective now, so I think the Mars 2 has made me a little more selective and say, whereas before Mars 2, the guidelines were kind of open-ended, like biphasic could be done, what kind of, early stage, later stage, like it was all okay. Borderline resectable cases where patients may be a little sicker, or I knew I was still going to do a bigger operation, and we may have been more aggressive investors, like, there's not really much else out there. And that's still true. There's not much more else out there systemically, even with the immunotherapy. But now with kind of some of these morbidity, mortality rates that we saw with Mars 2 being pretty high, partly due to extensive surgical resection and not staging appropriately in sicker patients and biphasic and sarcomatoid, that is, maybe thought that like, hey, maybe we should take a little step back and really, really you make sure that the patient will most likely benefit from surgery. And we think those are earlier stage, meaning stage 1 and 2, maybe stage 3, but again, systemic therapy, but in doing upfront surgery, making sure they're adequately staged, making sure they're epithelioid, making sure they're truly healthy enough to undergo a surgery, I think is really comes more at the forefront. So we're more selective, and we're really, before it's like, oh yeah, they go to surgery because there's nothing else. Now it's like, okay, well, let's really make sure they're okay for surgery. I think that's what it's changed my practice at. So it has helped the field, don't get me wrong, for less surgeons and us people that perform surgery for this, for this disease, but it's hurt so many more in terms of limiting now all those other patients that was already hard to get to us now don't even have a chance.
I was going to ask you, what your advice would be to clinicians or patients, but you've given a lot of really good advice already. So I just wanted to ask, in conclusion, if there's anything else you would like to say about maybe clarifying the Mars 2 trial, or for any confusion that you think clinicians or even patients might be experiencing now with mesothelioma treatment, what would you tell them?
Yeah, my main thing is what I'd see to summarize for patients, clinicians is that while Mars 2 is an important part of our data set, because of the limitations that we spoke about earlier, meaning not adequately staging the patient. Some of the patients that were operating were stage 3 and 4. Some of the patients were sicker. Some of the patients underwent kind of excessive surgeries that maybe didn't need to always be done. And then different histology subtypes, all of the different, and then just the trial design of getting chemotherapy first, which we know isn't that great for patients and doesn't respond well for mesothelioma, and then weakening them. And then even after surgery, those patients, the majority did not, and the surgery arm did not get the chemotherapy, extra chemotherapy like the chemotherapy arm did. They just got more chemotherapy than the chemotherapy arm. So all those different flaws that we talked about, it still tells us that, yes, we just have to be more selective and really take it seriously. So with that being said, what can I urge is that it should still, regardless of Mars 2, these patients should still be seen by surgeons. For essentially stage 4, that's different. I think if you know that they're stage 4, that's a little different. I'm not expecting all those patients to come to me right away, right? That's a nuanced approach. But I do think, stage 1 through 3, regardless, should still be evaluated by a surgeon early on, because the surgeon will also be able to help whether or not they recommend mediastinal staging through whether through EBUS or through mediastinoscopy or other tests they may do. Some surgeons stage laparoscopically as well, just to make sure there's nothing in the belly. Either way, the surgeon should be involved up front like they are for lung cancer or any other cancer that we deal with in the chest. So I think that should continue, Mars 2 or not. And right now, what I'm seeing is post Mars 2, we're not seeing as many patients. And providers are, and even worse, and I didn't get into it, but even worse, providers are not tending to maybe even be aggressive about trying to find a biopsy first to see if they actually have mesothelioma because they think there's nothing to do anyways. It's only systemic treatment, so why do anything? Or go on hospice or go to palliative care. All these kind of old school thinkings because the patient's never going to want chemo and that's the only treatment option. So they'll be like, well, if it's meso, regardless, you're just gonna go on chemo. And a lot of these older patients don't want to just go on chemo. They want to know that, I can get surgery too, and then I get radiation too. And so there's all these biases now going on even up front. So what we're noticing in our system, unfortunately, is that we don't know if that's because of Mars 2. I don't have data for this, but we know significantly over the last year, our diagnoses, because we have a pathologic diagnosis system where we can pick up any mesothelioma in our system. We're seeing way less diagnoses all of a sudden just drop off. And we clearly know that asbestos exposure, if anything, is still there. And you would see we are expecting more increases in mesothelioma diagnosis. But pathology-wise and biopsy-wise and procedure-wise, we're seeing less and less of that. And so I think that's even more of a problem. It's not that these patients don't have mesothelioma now, it's that they're not being diagnosed or biopsied early enough or aggressively because the thought is like, well, if there's no treatment for it, surgery's no good. What does it matter if we get a biopsy now up front when you see a pleural effusion versus 3 years from now? What does it matter? And I think that's definitely coming hand in hand. So you still have to biopsy. You still have to know it. If you can catch this early stage, regardless, early stage, late stage, but especially early stage, there's still very curative, quote unquote, type. Can't get rid of it, but improve survival type intent for cure, not just palliation treatment for mesothelioma. And so that all needs to be done. So our mindset shouldn't change. And so I would say don't change because of Mars 2 in terms of how it's worked up and how it's evaluated. Let us as the surgeons evaluate how we want to take it Mars 2. And because there's plenty of the surgeons out there, as you know from your surveys, that it has influenced them. And so, but at least they're getting to see that patient. Let them see that patient, and then they can say, no surgery. I'm going to go with Mars 2 or whatever. But let us evaluate that patient. And right now, I don't think that's happening enough. The other thing that I forgot that we were coming up with that we just presented at the AATS ITSOS meeting in Boston last week is we have our real world results of what we did in our system, in our healthcare system in California, and how we treated in a multimodal approach, which is we treat with surgery first, followed by systemic therapy. And when we compare that, again, it wasn't a complete perfect comparison, right? Because it's retrospective and not randomized controlled prospective study. But regardless, when we look back and we match and we try to adjust for as many things as possible, what we did see is that significant improvement in survival in the surgery plus chemotherapy group versus the group that did not get surgery, even if they could qualify for surgery, meaning early stage epithelioid, the ones that didn't get surgery because they just didn't want it. And when you compare that and they just got chemo, we saw significant improvements in survival in the surgery plus chemotherapy group. And so that could be another update like that we could show. And we're hoping to publish that actually very soon because we just submitted the manuscript to Journal of Thoracic and Cardiovascular Surgery. So if that comes out, which hopefully will be soon in the next few months, that's going to even be better, more evidence to say, hey, look, this is the first published data since Mars 2, again, being retrospective, but a real world study of, hey, look, that we see survival benefits and this is how we treat mesothelioma. So I'm excited to hopefully we can comment on that when that comes out.
This is all such great information to bring up. So I want to thank you for your passion on this topic and, your own research and your own expertise and everything and sharing that with us. I think it would definitely be worthwhile to follow up with you maybe near the end of the year, early next year to see how, if there is an expansion into Mars 3 or just how people are still discussing this. I think that would be fantastic. But overall, I wanted to thank you so much, Dr. Velotta, for your time today.
Yeah, absolutely. Thanks so much.